Thank you for joining us for Conversations in Relapsed Refractory Multiple Myeloma. During this segment, we'll be discussing insights into the use of bispecific antibodies and recent evidence. I am Dr. Jesús Berdeja, the Director of Multiple Myeloma Research at the Greco-Hainsworth Centers for Research at Tennessee Oncology. I am joined by my colleagues, Dr. Joseph Mikhael and Dr. Saad Usmani. You know, in the last section, we talked about 3 new bispecifics that have been approved and are now in use in relapsed refractory multiple myeloma, teclistamab, elranatamab, and talquetamab. So, you know, there's a lot of excitement around these drugs, and we're all now starting to get a lot of experience in how to use it. But I actually wanted to kind of get a little more into the details in terms of how you're using these drugs, and then maybe start talking about how we anticipate they'll be used in the future, and then maybe get a little bit into how we manage some of the side effects that we're seeing. So perhaps I'll start with Dr. Mikhael. So in your institution, how are you giving these? Are you doing all outpatient dosing? Are you giving it inpatient? How are you proceeding with these therapies?
Well, your timing is good, Jesus, because we've actually just recently made the decision to really try and go exclusively outpatient for it. We've still refining our outpatient program for elranatamab, so we're not providing that just yet, but we are giving both teclistamab and talquetamab as an outpatient exclusively. So we use some of the same, if you will, machinery that we use for our outpatient transplant program, which is predicated on a few things. One, we want to have a very strong communication relationship between our team. In particular, we have a nursing staff that are in constant communication with the patient. And 2, that every patient has to have a care partner alongside of them who can help us monitor. And then thirdly, we have remote monitoring. So we have devices that our patients have that can follow their blood pressure, their temperature, their heart rate, sort of the basic vitals. And then when we give the dosing, we can monitor the patient in the therapy unit for the day, but at night they go home. And then as we're continuing to follow them, especially at the higher risk CRS periods, we're following them every 6 hours, 4 to 6 hours at home with a phone call, and we're doing the ICE score. So the patient, fills out a sentence, and certain things are recorded. And if there are concerns about emerging CRS, then we have an ability to bring them in-house. But we're trying to do them exclusively as an outpatient.
That's wonderful. Saad, how do you guys do things in New York?
No, so I agree with Joe. I think, when teclistamab got its FDA approval, we were, trigger happy in creating that outpatient model, after our initial, 10 or 15 patients, just to, prove to our institution that the CRS rates and grading that we're seeing in our population is similar to what has been reported in literature. And it's not the same CRS concern we have for CAR T patients. Most of the CRS happens in maybe a little over half of the patients, and most of that is grade 1. And that's honestly Tylenol management for the most part. We don't give TOCI to majority of our bispecific patients. We do, however, for patients who have high burden of disease or that have logistic issues, we still treat them inpatient, but we do have an outpatient administration, schema. And then, just as Joe mentioned, we do have a digital wearables, monitoring Q&I project that Dr. Corday from our program is leading. And essentially, New York City is a very different beast, than other cities. So, we have to, create this QI project that can eventually be followed by our lymphoma colleagues, and bispecifics are coming in solid oncology as well. So I think, it will help, our cancer center in general.
Yeah, no, thank you. I think that's great. And I couldn't agree more with the cytokine release and neurotoxicity. These are the side effects that we're always so afraid of, right? When CAR Ts first came on board, and when we should definitely respect them. But I agree with you. I think the percentage of cytokine release is high with bispecifics, but I think the grade tends to be relatively low grade. So I guess you probably answered my next question, was going to be, do either of you give any kind of prophylaxis to keep these patients as outpatients, steroids or tocilizumab?
We haven't done a prophylaxis yet, Jesus, but I have to say, and I think I've been a bit influenced by, having conversations with a lot of our other myeloma colleagues across the country. I being out here on the West Coast, we speak to our friends at UCSF a little bit more, and they, in their words, they're a little TOSI trigger happy. So the patient is feeling feverish. Again, I don't mean to make light of it, but I think whereas we really almost waited for sure to have a grade 2 to introduce TOSI, now I think we're a little bit more comfortable. Just any fever will respond with tocilizumab, and it seems to be able to nip it in the bud. We obviously may have to have a few administrations of it, but more often than not, we found that that's been helpful to manage them, and subsequently not have a higher grade CRS.
I was just going to say that the algorithm that we have in place, the first fever, patients gets acetaminophen. The second fever, they have dexamethasone at home, which we prescribe ahead of time, and we ask them to go ahead and take 20 of dex and come on over. And after arrival, we monitor them. If they have another fever, they get TOSI, and then we monitor them, and then eventually let them go. And that's kind of like the workflow that we follow for our outpatients at the moment. But most of that CRS, again, I want to emphasize that it's low grade and can be managed effectively.
Yeah, no, I completely agree. Just to balance you guys out a little bit. So obviously I'm in a large clinical practice, and so we are still admitting patients, but we're actually we're in a different situation where our clinic is separate from the hospital. So we are dosing as outpatient, but then our partner hospital does the observation admission as per the FDA, and mostly just because of logistics, not because I agree with you all that I think these are very manageable toxicities in outpatient, but I think it's important that everybody's going to have to kind of figure out the best way that works for them. And so, one of the things I do that at least I've seen is I agree with you all. I think, we probably don't need to give as much TOSI as we do. The only reason that I do kind of agree with the UCSF group is that, at least in my experience, once you treat it, it's unlikely you're going to see it again with any of the other doses. And so that's one of the potential reasons to intervene early, is just then you kind of like free from the rest. But I agree. I think it's an expensive medication. We shouldn't be just using it willy-nilly, but definitely it's a good thing to have an armamentarium for sure. So that's excellent. So one of the other concerns I've heard, though, is so you're giving these drugs and your patient lives. We'll move to California because they're more likely to live further away. Do you send the patient back to your referring doc? Are you seeing roadblocks in sort of them accepting the patient back?
Go ahead, Saad, after you.
I was going to say I don't think that once patients have gone through that CRS concern period, that community colleagues are they're okay with taking the patients back for usual administration. However, the first 2 or 3 months, we still keep a close eye on things because of that infection risk concern with BCMA-directed bispecifics and with GPRC5D, the skin, nail, dysgeusia concerns. Once you have a better idea of what the signal will look like, what the activity is, you can advise your community colleagues to perhaps try a different dose or schedule based on management, because these are real world patients. So what we've seen is that continuing the more frequent dosing is suboptimal for them because they start having more adverse events that way. But yes, there is a reasonable comfort level that the community colleagues take those patients back, but they do want that connection and cushion from us to guide them during that early period. Joe, please. I'm sorry. Go ahead.
Yeah, no, I think I know. I mean, shocking. I always agree with you, Saad, but I think we faced a little bit more hesitation here, I have to say. So when we first built it, we had this plan that at 12 weeks, everybody goes back to their community oncologist who came from them. And a lot of them are just very nervous, even if we're outside the natural CRS and neurological window. And we can't blame them, right? I mean, these docs are caring for patients with 50 different tumor types. They can't keep track of all these new drugs, and we want to support them. In fact, I'm very concerned that if we force that too much, that we're going to build a greater divide between academia and the community. And I work in a very unique center where we're sort of nested in a community area. So this is particularly real. So they've been quite nervous about receiving them. But when we're giving as we're naturally doing, particularly with teclistamab, and naturally occurs with talquetamab, reducing the frequency of the dosing, that has been helping. But the vast majority of our patients on teclistamab also need IVIG. Thankfully, the community docs are comfortable giving that. So sometimes we get into the shared care model where, we'll keep giving the teclistamab, but then we sort of, one step at a time. Okay, you give the IVIG, you're checking on them a little bit more, and they're kind of going back and forth to slowly, hopefully, facilitate that transition, which some centers have been more comfortable with.
Yeah, no, thank you. That's excellent. So the only thing I would add that I've seen, at least in our practice, is it's sort of the logistics and sort of what's required by the sponsor and the manufacturers and the REMS programs, right? So we just talked about how CRS and neurotox happens in the very first cycle. It's very manageable, and often we don't even use tocilizumab. But the requirements remain. So if the patient goes back to their treating doctor, they are required to have tocilizumab on hand, and for these potential side effects that we know we see maybe in 1% of the patients after that. So I think it's just a plug that perhaps we should sort of ease some of those restrictions as we move forward, as more patients get treated. Perhaps we'll see less of that reluctance to take those patients back. But I completely agree. It's still new. There's toxicities that we need to think about and monitor our patients well, because we don't want bad outcomes. And so in that vein, since we've been talking about some of the side effects, once we get past that first cycle and the CRS and neurotox is sort of kind of out of the way, the main thing we're seeing, especially with the BCMA bispecifics, is infections. And unfortunately, the infections, at least the way the antibodies are currently approved with weekly dosing, those seem to continue through the lifetime of the antibodies. And I think, Dr. Usmani, you talked a little bit about, touched up a little bit on some of the things we can do, but perhaps I'm curious, what are you doing for prophylaxis? It sounds like you give IVIG as well, and then the question is, how do you then de-escalate therapy?
So, in addition to IVIG, and, most of these patients, that we're treating out in the community would not have made it to Majestic 1 or, Monumental 1 or to Magnetism 3. So, we have to be cognizant of that. Many of the patients are coming in with, quite a degree of immune suppression or I would say qualitative and quantitative immune deficiency. And so, we have to be mindful of that. We typically do is VZV and PJP prophylaxis for these patients, similar to what we would do for our CAR T cell patients getting BCMA-directed treatments. In general, we try to follow the package insert administration of drug for the first 2 cycles as much as we can before backing off of the dosing. If we start seeing patients getting into a partial response or better, I'm very comfortable with moving to every 2-week and then eventually every 4-week dosing of treatment. This is what, we've talked about this in other forums, amongst ourselves as well, that, these therapies, get their initial approval based on, very rigid clinical trials. And then we figure out how best to use them in our clinics. And that's what, all of us are trying to do. And I do feel that that de-escalation of the schedule, is going to really help a majority of our patients mitigate this infection risk.
Excellent. So just to move on to a little bit different. So we're myeloma docs, right? So we love combination therapy. So Dr. Mikhael, what combinations are you excited about with bispecifics, or are you excited at all? Should we just be giving it a single agent?
Well, I think right now the best evidence we have is single agent, but I am excited about combinations and new targets. I'm interested in the FcRH5 target with cevostamab. The response rate may not be quite as high yet, but I like the idea of targeting it a different way. In our lab, we do a lot of studies trying to understand how people become resistant to these drugs. It's actually different with teclistamab than elranatamab, for example. So we do think that there will be opportunity for greater exposure with time with different drugs. But I think nonetheless, we like a new target. That being said, it's hard to argue with the study that that combined teclistamab and talquetamab together with an over 90% response rate. That being said, there's still the two toxicities. They're not that overlapping, but people experience them. I'm very interested, and I won't get too futuristic, but I'm interested in the tri-specifics. Imagine if you could only hit cells that express both BCMA and GPRC5D. So, as opposed to and or, it really is or. It really is and. They have to express both, not or, where they express either of them. I think we're going to see the toxicities go down because those cells in the taste buds, the skin, the nails don't also express BCMA. So I'm hoping that when we have that kind of tri-specific with time, but until then, I'm not averse to using different combinations. As we've learned, I think Saad had commented that we've learned that combinations work better than single agents. But right now, this is still pretty impressive single agent response.
Yes, no, thank you. I agree. The redirect study with the combination of the two looks quite impressive. Any other combinations that are interesting, Saad? Do we be combining this pomalidomide and daratumumab? I think there's some data with that, right?
I think intuitively combining with immunomodulatory drugs makes sense. I think with BCMA and anti-CD38 combination, the early data, even though the efficacy appears to be good in the 80% range, I think there was an increased infection signal, and that would be my worry. The other comment that I can potentially make here is there are other BCMA-directed bispecifics coming down the pike, and they are some of them can be dosed less frequently. And may not require step-up dosing. So the ABV 383, as an example, can be given now every 3 or every 4 weeks and doesn't require step-up. So I think we still have a lot to learn from some of these biospecifics, and hopefully we might get some others that may have a better safety profile and schedule.
Yes, no, thank you. I completely agree. And the only other thing I would comment on is the cevostamab, right, the FCRH5 bispecific, which actually has limited duration of treatment for a year. And the data following those patients that actually completed the year is quite intriguing, with those patients remaining in remission for quite a while. So I think that's hopefully a lesson learned for how we're going to be using these in the future. But I actually would like to wrap up our conversation there. And so thank you again for joining us for this segment on insights into use of bispecific antibodies and recent evidence. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credits, access downloadable slides, as well as other topic segments and case scenarios. Thank you.